here at GI ASCO 2014 and sort of participating in the different sessions looking at the treatment of advanced colorectal cancer and taking particular interest in how we're treating metastatic disease, particularly to the liver. And a lot of interesting posters and presentations here looking at new therapies. And I think a lot of renewed excitement. We've got better body-wide systemic chemotherapy. We've got improved liver-directed treatments. So a lot of interest in sort of how to incorporate body-wide treatment, liver-directed therapy, new drugs. So I think a lot of excitement here and a lot of interest.
I'm here at ASCO GI reporting on a study that we did in patients with colon cancer where we subdivided them into KRAS mutant versus KRAS wild type and see how they did. So our conclusion essentially is that the KRAS mutant types need to be hit with everything early on and hard. But this is really an interesting finding, and the ASCO GI meeting is really the premier meeting in the world for those of us that are interested in GI cancers and their treatment.
Hi, my name is Philippa Burke. I am a patient with stage 4 or metastatic colorectal cancer, diagnosed 3 years ago, and really focusing on what is the situation for the stage 4 patient in terms of care, research, survivorship, and other areas that haven't been explored so much, like palliative care, and getting a better understanding of that and sharing it with other stage 4 survivors.
We have now chemoembolization, stereotactic irradiation, TACE, SIR spheres. These are beads that are containing radioactive isotopes, and you might have already had it.
Yeah, she had it.
And I have a number of patients who've been on and off these therapies. These active treatments can be combined with systemic chemotherapy, on and off, and that keeps many patients functional, active, enjoying life.
There's a lot of clinical trials and research that are being presented here, and there'll be more meetings and data being presented that we hope will help patients in the future. So there's hope for everybody all the time.
I'm here at GI ASCO presenting our recently completed randomized phase 2 study in patients with liver-dominant metastatic colorectal cancer. And so this trial essentially randomized patients who were chemo-naive to receive optimal first-line systemic chemotherapy and hepatic arterial therapy versus a control, which was just chemotherapy alone. And what we essentially demonstrated is that there was really no difference in toxicity. And so from this we were able to conclude that combination therapy is really something that should be optimally considered for patients with liver-dominant metastatic colorectal cancer.
I'm here to present a poster on a study I've been doing the last couple of years. It's following patients with liver cancer towards the end of life, and it's a longitudinal study. I also interviewed family members at the same time, and I followed both them and their sick relative once a month for 6 months. There is very, very little we know on the experience of patients living with liver cancer. Quality of life changes, maybe wishes and preferences changes. So we as healthcare providers have to be better so we get to understand them, but also be able to elicit information so we get a very clearer picture of what the goals of care are for patients and the families.
We're interested in new treatments for cancer. One of the specific areas is understanding mechanisms and developing treatments for chemotherapy nerve damage.
And we are here to present results of our study that we conducted in colorectal cancer patients.
It's very nice to see a station like this where you're saying say yes to hope, because of course that's why we're really in this business, is to hope and to be here to learn about all the amazing advances in cancer. Certainly today we're much further than we were 10, 20, 30 years ago. Patients are living longer, they're living better, and really, you know, when they come into our office, we tell them the plan, but more than that, they're holding on to this hope that they're not going to be the average, they're going to be the outlier who does better, and certainly some of them do, and you know, we're just all in this journey together to eventually conquer cancer, and hope is the only way to make that happen and to move that forward.
I think what really changes in our profession And this is a major landslide, like shift, a dramatic change in the whole landscape of cancer care today. It is that we more and more appreciate the uniqueness of each individual's cancer. So cancer in one patient may be completely different in a different patient. And in fact, we present tomorrow a poster of a series of cases where genetic profiling helped identify new drug targets, new options. And that keeps many patients who would be, having no options and going to hospice. It keeps them functional, alive, doing well. I think patients should not be passive participants in the treatment process. They have to be actively engaged, ask questions about, doctor, what else do you know? What is the genetic mechanism of my tumor? And active participation in clinical research, pursuing ideas that may be experimental. This is what we all have to do, and patients included. So stay active, stay alive, fight, and hope is around the corner.
I deal with hepatocellular cancers, primarily very interested in research. There's new and exciting things happening with new drugs and breakthroughs. There's always hope for a better tomorrow, and yes to hope.
I'm Dr. Joshua Ellenhorn from Los Angeles, California, and I am a surgical oncologist treating patients with liver tumors, and I say yes to hope.
I'm Gustavo Giroto. I'm a medical oncologist in Brazil, and I treat patients with gastrointestinal cancer, and I say yes to hope.
Dis oui à l'espoir.
So say yes to hope.
Yes to hope.
Say yes to hope.
Say yes to hope.
Tak dla nadziei.
Say yes to hope.
Say ja till hopp.
Yes to hope.
Yes to hope.
Say yes to hope.
We say yes to hope.
Say yes to hope.